Our patient is a 69-year-old woman with a history of diabetes, hypertension, and chronic kidney disease, brought in by her daughter due to concerns about forgetfulness. Our patient does not feel that this is a big problem, but her daughter has noticed she has been forgetting much more lately. She initially started forgetting names and where she put things. Recently, she has been losing her train of thought mid-conversation and forgot to add sugar to her favorite cookie recipe. What prompted this visit was she recently forgot about her grandson's birthday party and skipped it entirely. She remains quite independent and still drives, cooks, and cleans her home, but she has been somewhat more isolated since her husband's passing last year. Both the patient and her daughter would like to know if these are signs of dementia and what they can do to prevent further progression. In this podcast, we will discuss mild cognitive impairment and dementia in regards to screening tests and methods for prevention and management.
Welcome back to the Ogden Surgical Medical Society podcast. We are still under quarantine at this time, but things are getting a little lighter out there. But today we're going to step away from COVID-19 to talk about something that's persisted a lot longer than the coronavirus. And we're going to be talking about dementia. My name is Clark Madsen. I'm going to be one of the hosts. I'm a family physician and sports medicine physician at McCady Hospital. And today I'm joined by our other host, Jake Saunders. I'll let him introduce himself.
I'm Jake Saunders. Currently, I'm a third-year family medicine resident at McCady in Ogden, Utah. And next year, I'll be working with Midtown Community Health Center. I'll be graduated in just 2 months.
Yeah, you can't say resident for very much longer, Jake. You are on the very edge of graduation. So, hey, congratulations. If anyone sees Jake in the hospital, make sure you go up and congratulate him. He's definitely earned it. I'm happy he's sticking around in our community.
Well, I'd like to introduce our guest here today. We have Dr. Kevin Duff. He obtained his PhD in clinical psychology from the State University of New York in Albany in 2001, completed his neuropsychology internship at the Southern Arizona Healthcare System in Tucson, Arizona, and his postdoctoral fellowship at the University of Oklahoma Health Sciences Center in Oklahoma City. He joined the psychiatry department at the University of Iowa in 2003, where he had clinical and research responsibilities working with patients with dementia, Huntington's disease, and other neuropsychiatric conditions. In 2009, he joined the Department of Neurology at the University of Utah as a neuropsychologist for the Alzheimer's care, imaging, and research. His current research has focused primarily on the early identification of cognitive decline in neuropsychiatric illnesses such as mild cognitive impairment, Huntington's disease, Parkinson's disease, progressive supranuclear palsy. Dr. Duff's work has been widely published in scientific journals with over 130 papers and has lectured nationally and internationally on his areas of expertise. And with that very impressive CV, we are grateful to have you here with us today.
Thank you very much. Good to be here.
Yeah, thanks for coming in, Dr. Duff.
Happy to.
Dr. Duff, we like to get to know our guests a little bit at first. What's something outside of that impressive CV and outside of work that you kind of like to enjoy and something that you would like to talk to us about?
I'm a sort of big outdoors fan, hiking, camping, but road biking is definitely my favorite activity. In warmer months, I like to ride in and home from work. It's about 13 miles each way. And I do that probably 2 to 4 times a week. And it's a nice way to clear my head both directions.
Nice. That sounds like great exercise.
It definitely is.
As a sports medicine doctor, I'm always looking for new opportunities for my patients to stay active. And I had a question for you. They have this new Golden Spike bike trail that goes all the way from up here in Ogden down to Provo. It's quite a long ride. Have you ever thought about doing that one?
I have not, but I would definitely look into that. And that does sound like a tough ride itself. I will say that it was mentioned that I was at the University of Iowa before this, and Iowa has a ride that's called RAGBRAI that goes from the western part of the state to the eastern part of the state. And I rode that twice in my time out there. It's a 7-day bike ride across the entire state. And everybody may think Iowa is flat until you have to ride it on your bicycle.
Nothing's flat when you're on a bike.
A lot more rolling hills. But I will definitely look into the Golden Spike ride. That sounds fantastic.
Yeah. I think I've heard of that. I've heard of that ride before in Iowa.
The RAGBRAI.
Yeah. Is that the one that involves more drinking than riding, or is that a different one?
So I actually ate more pie going across the state than probably riding. And despite riding for 7 straight days, I think I actually gained weight. So
that is
quite
an
an
accomplishment by itself.
somewhat.
I also was reading that you've been a frequent visitor to Africa. That you have a family out there.
Yeah, so my brother-in-law lives in Botswana, which is in the southern part of Africa, and he had worked for CDC and Botswanan government and Bill Gates Foundation, primarily doing HIV policy work. Last summer, my family and I took a trip for 10 days to visit him and see some of the sites. We were touring some of the wild game preserves, some of the beautiful national monuments and geography of South Africa, Botswana, and Zimbabwe. Made it up to Victoria Falls and Kasane National Game Reserve and the Nada Bird Sanctuary. It is the most as beautiful as Utah is, and it definitely is. Seeing some of the sites in the southern part of Africa, really fantastic. Yeah, very eye-opening, both for myself and for my family. I have 2 kids, one that's in high school, one that's in college, and it was really great for them to sort of see such a different part of the world. Really fantastic.
Wow. So definitely a high recommendation, it sounds like.
Oh, without a doubt, yes.
Sounds like you need to put that on the bucket list.
Definitely do.
Well, let's get started off right away talking about this important topic. Hey, Jake, why don't you get us going here?
Yeah, sure. It sounds like a lot of your research is in mild cognitive impairment. Would you mind talking to us a little bit about the basics of mild cognitive impairment and how you would define that?
It's a great topic because I think probably a lot of your listeners are familiar with dementia. And we generally define dementia as somebody that has significant cognitive impairments or difficulties with their thinking abilities, problems with memory or attention or problem-solving skills. And in dementia, those thinking abilities are usually so impaired that they interfere with a person's ability to do day-to-day type things like driving or managing their medications or preparing meals, things like that. In mild cognitive impairment, it's sort of an earlier phase of that. So the person still has significant difficulties with their thinking abilities, memory or problem-solving skills, but they're not so severe that they interfere with day-to-day activities. So they're still, even though they're having significant problems, they're still able to drive or live independently, things like that. So this mild cognitive impairment, but we think those individuals are a significant risk of progressing or getting worse and converting into dementia a year or 2 or 3 down the road. So it's a high risk group that we try to track very closely because we know they're at higher risk.
And it seems like some of those symptoms can maybe be kind of subtle. What are some of those kinds of initial symptoms and some of the first signs that you see?
Yeah, very much so. And they are real subtle. Sometimes the transition from what we consider as normal changes with aging into this mild cognitive impairment are tricky to pick up. But, we all struggle from time to time with remembering a name or a word that we want to use or why we went into the garage, what we had intended to get. Those are normal type things. But the more that they become a change from that person's past, the more that they start to interfere with the person's ability to do some of those day-to-day activities, the more frequent that they occur. That's when we start to get worried about them. What I found interesting about cognitive symptoms or memory changes is that there's no one thing that says if a person has this, if they present with this particular symptom, that's definitely a sign of bad things to come. It's more a change for that person. Let's say that there's a person who's always struggled remembering names and they're not getting any worse, but it's about the same and it's not really interfering with their ability to do day-to-day things. I probably become less concerned about that person. But if there's a second person who used to be very good with names and now they're starting to struggle, that person I'm much more worried about. So really it's a change in that ability or difficulties that we become more in tune with. And a lot of times we get that from a close family member, a spouse or an adult child may say, mom or dad used to be really good with this and now they're really having difficulties. those are the patients I think we want to follow a little more closely.
Yeah, I kind of tend to notice that in my patients. They don't seem to see it as much in themselves as their family members do.
Yeah, it's unfortunate, but insight or awareness can kind of drop off the more severe the symptoms get. That the person themselves may not notice that I'm struggling to remember names, or I'm struggling to remember to take my medication, or to, how to prepare meals. It may be other people around them that start to notice that first.
I was reading a review on this topic, and it almost seemed to imply that if the patient is coming in saying they're having problems with their memory, it's more likely to be depression related than to be actual dementia, and vice versa. If the family's saying it may be more early cognitive impairment.
Yeah, that's very true. We definitely in our clinic see a number of patients that we might otherwise consider sort of worried well, that they're starting to notice these very subtle changes. But when we do more objective testing, like what I do in our clinic, we notice that they're doing very well compared to their peers. And maybe that heightened awareness or arousal might be more anxiety or depression, as you mentioned. But you're right, when they seem to come in and say, I'm doing just fine, but the family's saying, no, there's definite changes here. Again, that's the patient I think we're more concerned about.
And this is an interesting topic because I think it's just so common. At least in my practice, I'll see 4 or 5 of these early cognitive cases before I see an actual dementia case. Oftentimes those have already been diagnosed, but these early cases are kind of tough because you want to know how aggressive do we need to be? Is this going to progress? So it's great to have you talking to us about this.
Yeah, and I would agree that these cases are probably more prevalent than more frank case of dementia where that person has impairments both in cognition and day-to-day activities. These subtler cases are much harder to pick up because in a lot of ways they still seem like they're very much intact or normal. And in fact, even sometimes on brief screening measures, it's hard to pick up these cases that on a full steam mini mental status exam or a Montreal cognitive assessment like the MoCA, they still may score largely in the normal range. And you may think, oh, this is maybe just one of those worried well cases. But tracking them across time seems to be, especially for primary care doctors who have regular engagement with them, probably much more likely to pick up on some of those subtle changes than somebody who sees them much more infrequently.
And kind of talking about any of those tests, is there any particular that you tend to use or would recommend for kind of helping with screening and maybe diagnostic?
I could say that, we prefer everybody to come in for a, 3 or 4 hour neuropsychological evaluation, but we realize that that's not practical in a lot of instances. It's not a good use of resources, and not everybody wants to do that. I think even some of the brief screening measures like the MMSE or the MoCA, or another one that we use quite a bit here is the mini-cog. It's a brief, 3 to 5 minute test. I think tracking them across time is probably going to help you identify it better than a one-time evaluation. Again, a one-time evaluation, the person may do just fine on the test, but if you see them back 6 months or 9 months later, or maybe for an annual visit, and you're doing it again and starting to know this is coming down, a tick here, a point there, that's probably the time to kind of get a little more worried about it. But we definitely appreciate these screening measures, even though they may not be perfect, much better than just asking a patient, how's their memory? Because as we mentioned, they may not have that insight and may not appreciate how they're doing.
Yeah. I think I was reading that tests like the mini mental status exam and the MoCA tend to have sensitivities and specificities in the 80% range, but that's a great idea. I never thought about doing that before, but being more chronological in it and checking them every once in a while, I bet that would definitely help.
Yeah, I think it really heightens that sensitivity and specificity more into the 90s. They're still great measures, and we still would much rather have that than no information. But I think, tracking across time would tell us a lot.
And that's kind of one advantage we have maybe with our Medicare wellness exams as well, that we have them always do a clock and kind of like a mini cog with that as well. And we're doing that annually, or at least should be.
Yeah, I think one of the big sort of advantages was when the annual wellness visit started to include some measure of cognition. I think tracking that across time helps us and helps you know when somebody is more at risk and maybe needs more services or when some intervention might be necessary. Just going off complaints can be trickier.
So, kind of on that note, we do the brief exam with our Medicare patients every year, but the U.S. Preventative Task Force currently doesn't really make recommendations for or against screening. It kind of sounds like, from your point of view, screening, isn't necessarily a bad idea, especially if people have some concerns.
Yeah, or in addition, if the family has concerns. So, I mean, yeah, I agree. The task force, recommendations. I think that'll be an evolving sort of document and situation, and we'll see. But I think, yeah, the more patients and/or families are concerned, I think that raises the bar on the number of people that we should probably be screening.
And so once we tend to get a patient that has some concern for maybe some mild cognitive impairment or other neurologic dysfunction in this way, what kind of testing would you do you undergo at next to this next step? And I know that you kind of do some research as well on this next step as well. If you could talk a little bit about that.
One of the few ways that we can really kind of definitively identify something like Alzheimer's disease is, on an autopsy. And a lot of my patients don't want to do that right away. That's not the first line, no. First line, action. So typically, we recommend, a thorough taking of history about the onset and the progression of any changes in memory or other thinking abilities, a thorough history of possible reversible causes of cognitive difficulties, like you mentioned. It could be depression or anxiety. It could be low thyroid. It could be, a host of medical conditions that sometimes mimic that. So we want to rule those things out kind of right away. A neurological exam, maybe including a mental status exam, can be really helpful at trying to identify, might there be other potential causes, any signs that might indicate a small stroke or something like that can also lead to cognitive problems. We depending on the results of that, a CAT scan or an MRI of the head, the brain, can be indicated if you think that there are some problems there. If you think it's more than just the person's heightened awareness and concern, if you think there's something actually, worrisome, then, that makes sense. And additionally, for people that it seems like it's appropriate for, if all the other signs are worrisome, referring them on for a neuropsychological evaluation. So we can look a little more in depth at some of those thinking abilities. The MMSE and the MoCA are great, but essentially we get a raw score. And we don't want to compare a 60-year-old same raw score to, say, an 80 or a 90-year-old. A lot of the tests that we have, that we administer, we want to directly compare a person of that same age and education background to their peers. And also looking at a wide range of cognitive abilities. A lot of the screening measures can have false negatives, and we want to make sure that we're not missing somebody that actually is having some difficulties. I've definitely seen some patients over the years who have scored perfectly on the MMSE or the MoCA, 30 out of 30. But when we get them into the clinic on more sensitive measures, they still show up with some subtle but clear deficits in certain areas that might suggest more intervention is actually needed at this point.
That's a great takeaway point. That even if your screening test doesn't really show it, but your history, just you're talking with the patient, you really get concerned. It would probably be good to refer them either way.
Yeah, I mean, you see the patients and know the patients so much more than any specialist who's going to see them for the first time. I would say that primary care doctors probably have so much more useful information, this whole sort of background of, I've seen this person, yearly over the past couple of years for these medical problems, and now I'm starting to get a different vibe from them, and their family starting to tell me that they're concerned. And even if that person, gets a 28 on the MoCA, you're still concerned enough that said, I think maybe we'll send you on just to be sure.
And it's great having a resource like you when we're evaluating a patient for dementia. When I see that on my schedule, I have to take a second to calm myself down, because it's a lot of mental intensity to get the full history, make sure they're not on any other medications, look for other causes. And, it stretches it even in a 30-minute visit. And it's great to have someone like you who can take the time to really dig into it.
Right. That's very true. In 15 minutes or 30 minutes or even an hour, I think it's very challenging to go through all that's needed to do a proper sort of evaluation for dementia, and especially for this sort of mild cognitive impairment. We have the luxury of being able to spend 2 or 3 or more hours with the patient doing this thorough evaluation. I think sort of it's a good use of resources for the appropriate case to sort of move them along in the system.
Yeah, I think this would be a great time. I was kind of reading a little bit on your prior work. What kind of work are you doing right now with this topic?
As I think you mentioned, sort of one of the things that my research is focused on mostly over the past, probably 10, 15 years, is looking for early indicators of these difficulties. And so one of the things that I've been studying for about that long is this concept of practice effects. And practice effects are when we give somebody some of these cognitive or thinking tests, these paper and pencil tests, and then we repeat them at some point later. Normally, if I were to say come into your office and give you a memory test where you had to remember a list of 10 words, and then came back a week later and did that same memory test with those same 10 words, odds are you would do better the second time. You'd remember some of the words, you'd remember how the tests go. When we see somebody improve that second or third time they take the test, we call that a practice effect or a learning effect. What we know is that normal people do just fine. They show that learning effect. But as people start to show early signs of mild cognitive impairment and maybe even early signs of dementia, that practice effect gets diminished. They remember less the second time that they took the test. And the more severe it is, the more that when they take it the second time, it's almost like they took it the first time. So we've been using this practice effect, especially in mild cognitive impairment, to see what it tells us about making an accurate diagnosis sooner than maybe we would be able to otherwise. That it seems to tell us not just how the person's doing now, but we've done some studies to say that it'll tell us how somebody's doing a year or two down the road, which is maybe more important. And maybe some of our more interesting research is that these practice effects or lack of practice effects tells us something about what's going on within the brain. That when we look at people who have smaller practice effects, and then we do, say, an MRI scan of the brain, that the hippocampi, the brain structure involved in memory, tend to be smaller in those people that have smaller practice effects. And even some of our fancy imaging, we do here at the University of Utah at the Huntsman Center, we do these amyloid PET scans to see the amount of amyloid deposition within the brain that's related to Alzheimer's disease. Patients that have smaller practice effects have more amyloid spread throughout the brain. So we can use these practice effects sort of as a proxy of where the person's heading cognitively and what the disease pathology might look like in the brain. The real advantage is that these practice effects, they're inexpensive, they're non-invasive. We can collect them just about anywhere at just about any time. Whereas these expensive radiation exposing tests like an MRI or a PET scan, very costly and can't do them just about everywhere. So we might use these practice effects sort of as a screening measure. I just finished up a study where we were looking at practice effects as it relates to treatment outcomes. So do patients that show larger practice effects benefit more from treatment than patients that have smaller practice effects? So that's sort of the hypothesis. So we're still looking at analyzing the data, but it seems like that they do sort of portend at least the future of these people.
Any findings yet?
But so we've been doing a number of studies sort of looking at this same paradigm, mostly in these patients with mild cognitive impairment.
Well, I think that's really interesting. I did previously, I was doing research on concussions, and with concussions, we repeat tests frequently. And I was actually, trying to fight against practice effects. So this is an interesting reversal of that. And that's what really drew my attention, that you're actually using the practice effect as an outcome. And so that's really exciting.
Yeah, I'll admit, when I first started to do research in this area, tried to publish on it, a lot of my peers who would review this said, the exact same thing, that normally we try to get rid of practice effects and you're trying to use them. So I've gotten people to sort of come around to sort of my way of thinking. But, largely I think we look at practice effects as sort of this measure of sort of plasticity within the brain. And the direction that we're sort of heading is that it's not just practice effects on cognitive tests that are probably most useful, but really practice effects in day-to-day life. Day-to-day we're encountered with so many complex tasks, whether it's learning how to use a new ATM or learning to use a new online bill paying program, or the new car that we just got that has all these gadgets on it. How quickly we learn and adapt and cope with a new complex situation probably says a lot about what we kind of have as kind of cognitive or brain reserve. So I'm kind of taking this paradigm and trying to apply it to more day-to-day tasks than just things like the memory tests that we use in clinic.
Well, I'm going to bring this up when I have to teach some of my physician friends how to use a computer program several times in a row.
Yeah. If they're not learning the app the first time, maybe they should come see me.
Maybe. Well, that sounds like a really helpful testing. How does that compare to some of those more fancy tests as far as diagnostics and such, like the CSF amyloid and the...
Right. So we actually have fairly good-sized correlations between the practice effects that somebody shows on memory testing and how they perform or how the results of some of these fancier brain scans, diagnostic tests. And we don't ever think that practice effects will replace those fancy diagnostic tests, but many of those diagnostic tests are very expensive. A lot of them right now are still largely experimental. They're not really approved for regular clinical care. So we think maybe these practice effects could be used sort of to let you or others know what's the risk of this person. How much do we really need to move them forward to the expensive or the invasive, hard to come by diagnostic tests, versus how much is this person actually showing what we'd expect and are doing just fine, and maybe we can reassure them that we don't think there's anything really serious going on, that they're showing the amount of learning, the amount of practice that we really expect them to.
Shifting gears a little bit, say a person came to you, we initially had some concern based upon our screening test that they had some mild cognitive impairment. They started to forget some things, maybe had some deficits of the family that we're noticing. You did an examination and noticed that they had a decreasing practice effects. What would be some of your recommendations to kind of what we can do to help them in their day-to-day lives, and maybe some treatments that we could offer them?
First, about recommendations for day-to-day life. There's quite a bit of evidence out there to say that there are really three things, or sort of three classes of recommendations that we make that seem like they have benefits for brain health and probably these people that are at risk. The first being physical exercise. We know that people that get regular physical exercise, and it doesn't have to be biking the Golden Spike Trail, but walking the mall, or some swimming laps, or doing housework or gardening, anything that sort of gets the blood flowing, sort of gets oxygen and nutrients to the brain. And so we know that people that engage in more regular physical exercise, at least 15 minutes at least 3 times a week. That has some brain benefits. And I don't even have to tell you all about the other benefits that physical exercise would have on, the pulmonary system or the cardiac system. So physical exercise, great for the whole body, but especially the brain. And the second thing, probably not surprising at all, is cognitive stimulation. So we notice sometimes, in fact, quite a bit, that when people retire from especially a job that maybe was more cognitively demanding, don't really replace that cognitively demanding activity in their retirement years. Maybe they were working as a banker and they're responsible for balancing accounts and, really demanding work. And then they retire and they just sort of, sit around the house and watch television or, maybe engage some, but nowhere near that challenge before. We think that puts that person at risk for some additional decline. So whether it is reading or playing a musical instrument or taking a class at a junior college or listening to podcasts, things that sort of keep the mind sharp, definitely seems like it has some benefits for that person retaining cognitive abilities as they move along. I always think of examples with retired physicians that come in to see us that are engaged still, maybe not quite in the same way that they were when they were practicing, but they're involved in lifelong learning institutes. They're taking trips where they're expanding their vision on the world. Those are I think the success stories. I think it's the person that is not re-engaging their brain that we're going to be more worried about. So cognitive stimulation is probably the second recommendation that we make as far as lifestyle changes. And the third, again, not surprisingly, maybe is social engagement. So there is also a tendency for people to retire, that their world maybe gets a little bit smaller, that maybe they used to have a job where they interacted with this group of 10 or 20 people on a regular basis, 5 days a week, and they've done that for 40 years, and then they retire. And if they don't fill that sort of gap with other social engagement, we worry about some sort of slippage in their thinking abilities. So whether it's, engaging with church or volunteering at a professional organization or some community group, or meeting new friends, any of those activities that gets the person out of the house, and it could be starting a new hobby where you're interacting with this club now. Any of those activities seem like they have benefits for memory and other thinking abilities, as well as sort of general brain health. So those three things: physical exercise, cognitive stimulation, and social engagement. There's really quite a bit of research out there to show that, especially for people that haven't yet developed something like Alzheimer's disease, for people that are looking to try to prevent that from taking hold in the first place, engaging in these activities on a more regular basis seems like it is really beneficial. And again, these things have so many benefits, not just for brain health, but for physical health, for mood, for overall well-being. They're easy recommendations to make.
Not a lot of side effects for entertaining hobbies and socially interacting with others, right?
Exactly. Yeah. Good point. Yeah. Not a lot of downside of doing these things that we all know we should be doing, but things that when we're busy working, we maybe don't always work them in, but so much more important to work in afterwards, after we retire.
What about things like healthy diet and or maybe even supplements like I don't know, I've heard of ginkgo biloba and like vitamin E. What's kind of your thoughts on those?
Yeah. So first, as far as nutrition, and I'm not a nutritionist, but we do know that the brain needs nutrients to function properly and for us to think clearly. And so a healthy diet of proper nutrition is really key for people being able to think properly. There's no, I know you're familiar with heart healthy diet. There's no approved brain healthy diet, although people are researching things like a Mediterranean diet as far as might that reduce risk of dementia. Some of those studies are still ongoing. And maybe we'll find out a little bit more sort of down the road. Just so you're audience knows, I was at a conference a few years ago and saw that there was a study that said, unfortunately, chocolate is not something that improves people's thinking abilities. It was a study done that was actually funded by the Hershey Corporation that said even taking dark chocolate, even with all its antioxidant properties, I don't know that we could take enough of that. I still enjoy chocolate now and again, but probably not necessarily important for brain health, but a good diet definitely is. As far as supplements, over-the-counter things, a few of the larger randomized clinical trials looking at things like vitamin E and ginkgo biloba have not shown huge effects. Again, for some individuals, there may be some subtle benefits, but not so much that we feel everybody should be taking them. Again, low risk of taking, some of these supplements. The ones I actually get more concerned about are the ones that we see sort of advertised on late night TV that they promise if you take these pills that they will give your memory back to when you were a teenager. Usually you can identify them because there's usually 60 pills in a bottle, and if you order in the next 10 minutes, we'll send you 2 for the price of 1. A lot of these I kind of lump under the category of snake oil. And when I've investigated them, because I often get questions about this one or that one, I find that they don't have a lot of scientific evidence. They haven't done randomized clinical trials in humans. There may be some limited evidence to say in rats that these help rats run mazes faster, but no data to say that they actually help people. I would actually, for my patients, I recommend that instead of investing $19.95 or whatever in these pills, that they go out and enroll in a continuing education class or take dance lessons or buy a subscription to audiobooks, because I think those things are probably going to be more beneficial for them than some of these unproven, unregulated over-the-counter supplements.
And that would certainly be more entertaining as well, I imagine.
Yeah, definitely so. Yeah, I think there are a lot more benefits of doing those things.
Yeah, and I think that's seems to be the story of treatment for this mild cognitive impairment is, all these things we're not talking about medicines. We're talking about being just healthy, socially, mentally, and physically healthy. So if you can, just focus on that, that's probably your best bet. I'm always patients are always coming worried about or family members are worried about their patients. They're saying, this is something, horrible. I need a medicine to fix this. And sure, we've got the cholinesterase inhibitors, memantine, and, as you mentioned, vitamin E may have mild effects, but all of these seem to have very modest effect at best.
Yeah, it's unfortunate, and again, you probably experience this more than specialists, because I think you see patients more that they're expressing these concerns and have to be sort of gatekeepers for some of these medications. But it's true, if you look at something like the cholinesterase inhibitors, the donepezil, for example, most of the randomized clinical trials that they've done on patients with either mild cognitive impairment or Alzheimer's disease show at best, kind of a stabilization of the symptoms for anywhere from 6 to maybe 18 months, and then maybe a slowing of the progression, but the progression continues. So, I get really worried sometimes on television. I'm sure you see this too, that there'll be this story about this patient that had Alzheimer's disease and they were given coconut extract or maybe even donepezil or memantine, and they turned around and all of a sudden they were, back and driving and, doing all these things, living independently again and had no memory problems. I personally have never seen a case like that in the almost 20 years that I've been doing this, where it's turned around like a light switch. And I really worry that those cases probably didn't really have Alzheimer's disease or mild cognitive impairment in the first place, that there was some other condition that was going on. I think this person generally got better, but it wasn't because of wasn't treatment from Alzheimer's disease. So yeah, I mean, I think we want to be cautious in how we portray the benefits, as modest as they might be for patients and their families when they get them, because I know that they are looking for the magic pill that will turn everything around. And as you both know, most of our medications don't quite work that way. Yes, they in clinical trials statistically show improvements, but it might still be a modest improvement. So yeah, I completely agree with you on that. We have to temper expectations as much as we can.
Well, on the flip side of that, I do also know several primary care doctors who take the opposite approach, saying because there's no medication treatment for these problems, why should I be sending my patient off for further testing and diagnosis? What are your thoughts on that?
Yeah, the director of our center, Dr. Norman Foster, always talks about it as sort of diagnostic nihilism, that, yeah, if there's nothing we can do, why should we know? And, I guess we take a slightly different perspective on that. One, we often feel that it's very informative for the family to know what's going on. Sometimes family members come into us thinking that the patient, their loved one, is acting this way on purpose, that they're being obstinate, that they're not trying to pay attention and listen, and it gets the family member upset. And to find out that the family member actually has a brain disease, something like Alzheimer's disease, it can kind of give some relief to the family to know, hey, this isn't just them being difficult. Second is that knowing what's causing the problem can help us know and inform the family as to where this is heading. And maybe as importantly, what types of resources might this person need 6 months down the road, a year down the road, 2 years down the road? It's always difficult to have a conversation that maybe somebody shouldn't be driving, or maybe somebody shouldn't be living independently anymore. But I'd much rather have that discussion being informed and being able to give them, and the family and the patient and the other providers, clear information about this is the trajectory we see this person on. And lastly, our clinic has social workers and health educators that often meet with family members to try to help brainstorm about the obstacles that they're going to encounter when caring for a patient with dementia. And it's much better to have somebody to talk that over with than to sort of fly blind, pick up things in books and on the internet. And maybe the last reason that I would give, again, maybe not surprising given my background, but for research purposes, we know that the more we can do studies on patients in this very early phase, the more we can learn about what actually causes Alzheimer's disease and other kinds of dementias, the more we can understand about how we're going to treat them. So for informing us, the medical community at large, about what's going on with these individuals, we really kind of need them in the clinic to engage them in studies.
I imagine something that might be helpful too is if the testing is negative, and it could be some other cause as well, and like a treatable cause.
Right. That's also thank you for bringing that up, because you're right. We definitely uncover cases that maybe a previous healthcare provider had labeled as Alzheimer's disease, that we see them and say, this is not Alzheimer's disease. This might be depression. This might be low thyroid. This might be, something else going on. And maybe that something else has a more appropriate treatment than, cholinesterase inhibitors or glutamate antagonists.
And you mentioned a little bit kind of the natural progression of mild cognitive impairment and dementia. Would you mind reviewing that a little bit with us? Something we can talk about with our patients, kind of what to expect with that.
Actually, it's interesting. So this concept of mild cognitive impairment has probably now been around for, 10 or 15 years. And over that time, we've realized that not everybody progresses from mild cognitive impairment to Alzheimer's disease or some other type of dementia. We think that probably per year, about 15% of those patients convert. So if I saw 100 patients with mild cognitive impairment and then I followed them up a year from now, probably only about 15% of them would convert. Now, in another year, another 15% of them would convert. But we also know that some of those people, what we call revert back to normal, that we have some cases of, for lack of a better term, accidental mild cognitive impairment that we do testing and they fall well below, but on follow-up testing a year later, they're actually back to normal. And so there are some false positives with us in our testing too. We want to make sure that people are aware of that. But we do think that things for the majority of these people over 5 years or so will progress to the point that they will start to show worsening of their cognitive abilities. And frequently we see kind of a spread of cognitive abilities. It's not unusual for the first cognitive ability to be affected is learning and memory. So ability to remember a list of 10 words on a test. That might sort of fall out first. But if we think that this person is progressing towards Alzheimer's disease, maybe one of the next cognitive abilities that starts to decline is language. The person starts to struggle with coming up with words or names. And so language is frequently a second cognitive ability that progresses after memory changes. And then usually the next sort of one, again, if we think this is Alzheimer's disease, are these higher level abilities that we call executive functioning. So planning or reasoning or organizing, a lot of times those skills start to drop off. So when we see this sort of progression from memory problems to language problems to difficulties with executive functioning, we start to feel more confident that unfortunately this person is probably heading in a direction towards Alzheimer's disease. And as those cognitive abilities start to deteriorate, we do start to notice higher level day-to-day functioning start to decline. Interestingly, driving is not probably one of the first cognitive or day-to-day functioning abilities that starts to drop off. Driving, especially for somebody who's been doing it for 60 plus years, becomes a very automatic kind of day-to-day activity. We see more kind of complex, newer tasks kind of falling off first, like not being able to work the new remote for the TV or the new computer that they got. New day-to-day tasks are probably some of the ones that challenge those faltering cognitive abilities more so than more rote tasks. The patient that comes into me, the woman that's been cooking, the same set of dishes for 60 plus years, and now she's burning things or forgetting to put ingredients in, and her husband is starting to notice, hey, things aren't coming out the same, or she's starting to get confused. Those types of things usually is a little later in the course of the disease, the driving, the recipes. But it's those newer types of things that we worry about when those start to fall off in day-to-day things. Or maybe more complex things, like filling out a new payment for a new bill that they just got, or new insurance forms that they have to fill out. Those things can be really challenging early on with those cognitive difficulties.
Well, that's I think that's a really good description. And one of the hardest conversations as a primary care physician I have is deciding, we need to take your driver's license away or other activities like that. That can really shut someone down.
And truthfully, we actually can be pretty helpful in that, because we'll have some objective data to say that this person struggles with attention, which is a key to driving, or maybe they struggle with visual spatial skills, which are key to driving, or there are certain tests that we give that seem like they're more related. When people do poorly on these tests, their risk of accidents goes up. So we often play the role of kind of the heavy in situations like that, of gathering some objective data to say, this person probably shouldn't be driving anymore. But yes, you probably encounter that much more frequently on a regular basis.
Well, thank you, Dr. Duff, for spending this time with us. We've gone over time a bit, and I think it's just because it's been a really fun conversation. I really appreciate that. And kind of getting to your last point, we definitely want to finish off by you telling us, how do we get patients to come see you? What's the best way to contact you to send patients to you.
Well, thank you very much for having me, and I very much enjoyed this conversation. So I work in the Department of Neurology at the University of Utah, and one of our outpatient clinics is a cognitive disorders clinic. And any physician around the state could send a referral to that cognitive disorders clinic saying that they have a patient that they're worried about as far as memory, other thinking abilities, and that will usually start kind of a process of them getting in to see me or one of my colleagues.
Well, great. So we can search the internet for Cognitive Disorder Clinic at the University of Utah.
That's right, or the Department of Neurology, and you can get that information from there as well.
Perfect. Thanks for coming. Any last words you have, Jake?
No, I just very much appreciate it. This has been an excellent and enlightening conversation.
Also, just briefly, it's also a really relevant topic for here in Utah. For whatever reason, whether it's because folks retire and stay here in Utah versus moving to another state, we are at risk of increased rates of dementia. Over the next 25 years or so, the Alzheimer's Association, over the next 5 years in 2025, the Alzheimer's Association is predicting that we'll have an increase of 25% cases of dementia and related conditions to Alzheimer's disease just here in the state of Utah. And so very much relevant, and probably something that your listeners will be encountering more so in the next 5 years, even than maybe they had in the past.
Well, we definitely hope we'll have the benefits of your retesting research by then to help us if we got 25% more diagnoses to make.
Yep.
Well, thank you again for your time and for chatting with me.
Well, thank you. Again, this is the Ogden Surgical Medical Society podcast. We're very happy to provide another episode here for you, and hope you'll tune in for future episodes. We have quite a few things planned for you. I think there's some upcoming conversations with care for the homeless, and I think there's a history of medicine in Ogden planned in the future too. So definitely come back, listen to some more, and we're happy to be providing this CME since we can't be there with you in person. This podcast is put on by members of the Ogden Surgical Medical Society. It is directed by the board of the Ogden Surgical Medical Society, and Teresa Puskedra is our executive director. Today's hosts have been Clark Madsen and Jake Saunders. Sound and editing is by Colton Gomez. We thank you for listening and hope to have you come back for our next episode.